Good afternoon and welcome to this talk that will be delivered by Aisling O'Kane. I am Laura Stafford from the Faculty's Industrial Liaison Office. If you have any questions for our speaker today, there will be a Q&A at the end of the presentation. Please submit any questions that you have to the Q&A tab that you can find at the bottom of your Zoom screen. This talk is part of our Faculty's Research Showcase event. The purpose of this week-long event is to demonstrate the breadth of research capabilities that we have in engineering at Bristol to provide stimulus for conversation and hopefully future collaborations. I will now hand you over to Aisling, who will be talking about accessing the actual use of personal health, care and well-being devices and apps in the wild.
All right, thank you very much. So I'm going to be talking about lived experiences and personal health technologies, understanding the actual use of personal health and well-being devices and apps in the wild. So my name is Aisling. I'm a senior lecturer in human-computer interaction for health, and I'm in the Department of Computer Science. But I wanted to point out that first thing after my name, which is the BASC. Why am I giving a lived experience talk in engineering? Well, my MSc is in human-computer interaction, my PhD is in computer science, but I'm also an engineer. So I actually started in mechanical engineering at the University of Toronto, which shared its first 2 years of 4 with industrial. I got my first intro to human factors engineering. Fell in love. I was obsessed with the idea of studying people as the point of failure in systems, not wind tunnels and optimizing there, but a person as part of the system. I went on to work in nuclear safety and manufacturing safety for industry. I'm a professional engineer in Ontario, which is something to be said because Ontario gatekeeps that title quite significantly. But I was always absolutely passionate about applying this to healthcare, which is why I pursued academia to move into healthcare safety research. And healthcare safety research is very important. Human factors in healthcare safety is fundamental, and you can use human factors research to apply to healthcare safety. For instance, designing for human capabilities as part of system design, for instance, perceptual thresholds for vision or hearing. However, regardless, to err is human. Humans are a weird part of systems in engineering, and we do all sorts of weird things, but we also make mistakes and errors despite the training, despite the motivation. We take wrong actions, we make missed actions, we have confirmation bias, we apply a bad rule. Human error is a significant risk. It kills. It kills a lot of people. So in 2013, they're looking at the causes of death in the US. It was heart disease, cancer, and then medical error. Might be different this year with COVID around, but it is significant, and therefore it deserves the attention that it gets. And in fact, you can apply engineering, applied science, to the design of usability of these systems to reduce things like human error. So engineering personal safety, you need to engage in the physical limitations of people and how that impacts technology. You can choose the right person to use that technology. For instance, you don't hire someone who's colorblind to be a clinician or a pilot. You can design the human to fit the system as well. So this spaceman in the corner is a worn system to increase the capabilities so pilots actually don't pass out at G-force. But you can also design the system to fit the human. So for instance, in the 1950s, they used to build cockpits for the average male in the US. They tested it out on hundreds of people and it fit no one because even though it was for average, it didn't fit anyone. That's where they moved to adjustable sizes for seats. And here you can see the application of ergonomics and physiology towards an engineering problem. You can also engage with the cognitive limitations of people and how that limits technology. You can choose the cognitive abilities. You can make operators or users pass a test before using a system, and that is often the case with safety critical systems. You can train for cognitive abilities. There are significant numbers of diabetes training programs for people with diabetes, for instance, in order to teach them about habitual care with exercise, insulin, food, and technology. But you can also design the system to avoid cognitive limitations, and this is where psychology comes in. For instance, there are number entry systems that are adapted for the task to avoid human error. In the corner is an example of a number entry system for an optician. And you can see down the right-hand side, we have decimals, 4 of them, because opticians often use those. So instead of pressing the button 3 times to get 0.25 and introducing human error, you have 1 button, less human error. This is where you can see the application of psychology and learning sciences in human factors and our limitations. But there's also contextual limitations on when and where and how this technology is going to be used. You can choose the context. In the case of VR, there's a lot of really interesting things in digital health and care with VR, where that is the environment. And for instance, for cognitive behavioral therapy. You can also control the context. So for instance, in the bottom right corner, this is a bright, clean, enclosed surgical theater where you can have hands-free in the air interaction, and it works quite well. But you can also then design for the context, and you can see this in your mobile phones, and which are often used for digital health, where, for instance, if you're getting an important call, well, the mobile phone has a ringtone, it has vibration, it has lighting up, it might even be connected to your wearable. These are different modes for different contexts in which would be appropriate. For instance, a mobile phone going off in a cinema might not be appropriate. Lighting up in the middle of a dark night, probably inappropriate to wake up a sleeping partner and whatnot. And this is where we can see the application of anthropology methods and design practices come in. But what about engineering personal safety in the wild? So human error is not the only source of issues with personal health. When you're looking at personal health, these people are not trained nurses. They're not trained doctors. They are everyone. They are everywhere. You will note I don't use the word patient in these presentations because everyone's a patient. I'm a patient as well. So it doesn't make sense to use that label when everyone is. And when engaging with personal health and self-care, you're balancing this against all other aspects of your life. And you can probably have an experience of what your personal health was like during COVID, and managing stress and managing changes in household situations, and how perhaps that impacted how you were maybe self-caring with regards to physical exercise. People choose to use, not use, misuse, and abuse tech in the wild. And it's important to not just understand how it is used in the moment. So that's the usability. This is where human error comes in. It's when someone's using it at that time. What for personal health, though, it's a bigger picture. It is what happens before you end up using the technology. How do you perceive the technology? Are you choosing even to adopt the technology? After use, how was your experience with that? How was the emotional connection? How do you reflect on your use of the technology? Because that'll influence the next time you use it, or in fact, don't use it in personal health. UX in personal health is incredibly complex. People's living and physical contexts are very different. People's, in this case, one of the pictures is a homeless artist who's self-managing type 1 diabetes. Health, illness, pain, wellness, mental health, all different for different people. And that influences how people view technologies and engage with them. For instance, this man going through home hemodialysis, it's incredibly long, quite painful process for people who are quite ill, and that'll influence how they engage with it. People's digital literacy and health literacy are all over the place, and you don't have to look further than COVID to understand that. So the digital literacy and how people are using the NHS apps, or in fact taking it off of their phones when they should be using it, and health literacy around vaccines. People's social lives are different. Social networks, carings, dependence, responsibilities are different. And you're using personal health technologies in completely different ways than using it on yourself versus using it on your only child in the middle of the night when they're quite young. Emotions come into play. And of course, there's life beyond healthcare. Health isn't the only thing. And this is why we're not patients. We have work, we have hobbies, we come from different cultures, individual differences, personality, all of these affect the user experience of personal health and therefore the technologies. From my research, I look at the idea of this from user experience to the lived experience, because there's personal aspects of health. People have different health. They aren't just type 1 diabetic. No, they have a bunch of other things going on. For instance, if they have asthma, the steroids they use might influence their blood glucose levels if they have type 2 diabetes. There's private aspects of health. They aren't just someone using an app. No, they're using a technology to self-manage a condition such as HIV, which comes highly stigmatized and affects people's use of technologies. Also, visible aspects of health impact the way people use technologies. Hearing aids is a great example. So 6.7 million people in the UK could benefit from hearing aids, but only 2 million people actually end up using them. That is really bad uptake. And my research into it looks very much linked to the visible nature of this and the stigma attached with it. There's also the relentless nature of health, and I'm sure you have all experienced the relentless nature of dealing with self-isolation and COVID. There's a huge amount of burnout with taking care of yourself. And this is particularly the case for chronic conditions, something like type 1 diabetes, where you're thinking about decisions, every decision, exercise, eating, weather, impacts your blood glucose levels, which you're balancing all day, every day. There's huge amounts of burnout. And then just everyday experiences influence health choices. Some people choose not to bring technologies. If they wear a dress and they don't have pockets, well, maybe they're not bringing their inhaler this time. Maybe they're not bringing their EpiPen. If they do mixed martial arts, maybe they're not choosing to adopt an insulin pump, even though it would be better for their health, because that's where the site that was put on is where they get kicked on a regular basis. People are weird, life is messy and complex. So how do you engineer for personal health? So you need to understand safety concerns for human factors. And I teach this to undergraduates as well, the kind of the basis of this: task analysis, risk analysis, root cause analysis. You need to understand the root causes of these issues, often linked to usability, in order to find out where to improve. It lays bare the improvements for design. But what about for personal health in the wild, where it's messy, complex, and usability doesn't come in? Well, human factors looking specifically at the individual are not sufficient. Focusing on the time of usage is not sufficient too, because people live very complex lives. There's something happening before, there's something happening after. You need to look at the holistic socio-technical system. You need to draw on sociology and a range of different methods to understand the messiness of real-world use. And there is absolute value in understanding issues of use, misuse, non-use, in order to lay bare improvements and impact the design of new technologies. So that is my research. I study real-world lived experiences, and I do this in really 3 ways. I look backwards by studying existing, or what I call established, technologies. They're not the most innovative, but there are temporal aspects of experience. There's novel experiences. There's bugs with new technologies. If you try to study the brand new, you don't get access to kind of well-established routines and social structures that might influence the use of adoption and acceptance of technologies. The people that you study just focus on the bugs and the new technology. So there is value in understanding something that's kind of been established and appropriated into into normal people's lives in order to influence the lived experience of future designs. I also look to the now by deploying and studying current and newish technologies as well, because looking back isn't sufficient. You can't just do ethnography. It won't tell you the future. I've had many HCI design researchers who shame ethnography, actually, because they can't see the future with it. You can't ask people what they want. Henry Ford said this: if he asked people what they wanted in a car, they would have just said faster horses, because they weren't thinking about that brand new thing. So studying actual use is very important. But even with that, there's limitations, because you can't look forward. And so there are ways of looking to the future, through near future design focused research, because you can't study things that don't exist yet, but you still can get insights into how they might be perceived, adopted, and used, and therefore design insights as well. So I'm going to give you a few examples of looking backwards, looking to the now, and looking forwards. Looking backwards, here's a really old technology, but we've just done a study on it. Ewan Subats, who is a PhD student, led this work on stair lifts for aging in place together. So he did interviews and focus groups with established service providers, so occupational therapists, and accessibility center workers, and stair lift installers, to understand that established way of people getting, adopting, and accepting a stair lift. And he was able to map out this kind of occupational therapist, how they would get a stair lift, how the private installer might have this simple model of how someone would adopt and get a stair lift. And this is an old technology. This is an accessibility technology. It's been around for years and years and years. It's much, people put it in the same kind of a bin as like assistive technologies or handlebars for going in and out of the shower. That's new bathrooms for accessibility, stair lift for accessibility. At least that's how Bristol City Council sees it as well, who we worked with for this project. So Ewan went in and then engaged with those service providers, but also primary users before, after, and 3 months after use of a new stair lift. And it was a complex mess. There was this huge emotional journey in way people that would struggle with their chronic condition, other people would see them struggling with mobility, they'd influence them to try to get it, they would be bullied by grandchildren to get it, there'd be huge discussions. The amount of instances of crying in this paper is very, very significant, because it is incredibly emotional. It has lots of different players in it. It is not straightforward, and there's aspects of decision making, conflict, and trauma, and then kind of living with it, catharsis and independence. By studying this older technology, we were able to gain access to this established emotional journey, which we then can use to impact future smart home technologies that are also going to support aging in place together. With regards to studying the now, I've also studied kind of newish technologies when they've just come out and just getting picked up by people. With Samsung Research, we explored technology in the gym with early wearable adopters, using autoethnography observations, contextual interviews, and contextual project meetings with my master's student at the time, Misha Patel. By doing this in the mid-2010s, we were able to access this kind of new technology and gain access to how it would fit into a routine of the gym. We were the first people to actually study the use of a wearable in situ, so actual use. Misha would run beside the people as they used the treadmill. She'd pretend to do weights as they were lifting weights to gain access to this information. And she found interesting things around distraction, disruption, boring treadmill. They all wanted all the technology. They wanted to be distracted from that cardio. But if they're concentrating on form, some people wouldn't even have music on when engaging with the weights, let alone looking at their wearable. There's also information needs versus avoidance. So even looking at that same treadmill when they've just started and there's so much time left, they don't want that information. Whereas if there's only a little bit down in the countdown to 30 minutes of cardio, they want that information. Also, exercise influences use, and use influences exercise. So the technologies are not neutral. Not being able to track spinning on your smartwatch influence people not to do that exercise, or have very poor user experience, get very frustrated with it. There was one participant who started using the elliptical differently as soon as they got a wearable, because they found that when they used the arms, it wouldn't track their steps. So they stopped using the arms, which is half the exercise of the elliptical, because of the introduction of the wearable. So we were able to capture how this wearable, again, is not a neutral technology. It influences the exercise, the temporality, the motivations on use and non-use. Looking forward now, so looking at future technologies, we explored Alexa for health and care. So maybe you don't think this is looking forward, because Alexa is out there. It's been out there for years. It's a very, very well-liked, well-adopted commercial technology. However, Alexa Show isn't. It's fairly new, and the act of using Alexa for health and care is new. It's the adopting an existing technology to apply to a different context, which is health and care. We looked at the use of Echo Show for health and care with Bristol City Council with older adult households during the 2020 pandemic at the beginning. Through interviews with primary users and their household residents before, immediately after, we were able to gain access to how they would use it now, but also by doing user-centered design and co-design of health and care future-looking skills, we were able to probe what it would be like to use this Alexa for potentially for a quite significant healthcare and in fact clinical medical needs as well. So we found that self-isolation was exacerbated through COVID, and they were looking for social care and information needs, and they were using Alexa for this. Very useful for social support and connecting people, but not as an actor itself. So we had one household describe it as an absolute life-saving device in their family with an older adult, but in no way did it provide any kind of company for that socially isolated adult. It was only via other people using the video calling on Alexa Show that allowed for that. We found that the device facilitated self-care and also shared care through informal and formal caregivers. There are absolute boundaries and the level of trust that people had in this device and in the automation for actually providing health and care. Search queries were actually quite a social aspect of some older households, which were removed during COVID, and kind of combined search queries within the house for things like checking the weather before a nice walk, improved well-being, influence positively on relationships inside the house and with the extended household. But of course, there were trust issues for more serious queries, all sorts of cross-checking, not believing Alexa. So it has interesting potential for being an inclusive technology, providing accessibility in the home, providing an additional form of intimacy, which is incredibly important for people isolating, and also social engagement as well. And we're able to study the kind of now and probe people about the future to unpack that and lay bare these design implications. Also looking forward, we had a project finish up looking at machine learning for diabetes self-care. So looking at kind of human-in-the-loop interactive AI for diabetes. And this picture is kind of the ideal. So with our industrial partner, Quantify Technology, we were looking at getting data from diabetes sensor devices, Apple Watch, phones. People would be putting in manual data about the context that couldn't be captured manually, automatically. We'd be getting data for the diabetes community. We'd be feeding into the machine learning pipeline, and coming out the other side were personal benefits and type 1 diabetes community benefits. So this is the ideal. We're not quite there yet. So how do you study this? How do you get design implications for this? So we were really interested in how do you engage people in human-in-the-loop AI before benefit is realized. We did co-design sessions with 15 people with type 1 diabetes, and they received an Apple Watch and a Dexcom continuous glucose monitor, which doesn't seem so far-fetched near future, but the NHS doesn't cover a Dexcom continuous glucose monitor, and an Apple Watch is a little bit out of the price boundaries of a lot of people. So it was near future in that sense. We set up an ecosystem of technology that some people would have, but not the majority, to study what that might be like, and engaged people in 5 co-design workshops that involved engaging with storyboards and scenarios and sketching and mock-ups. What was interesting about this is that it did provide design implications for interactive AI for machine learning and diabetes. And what was really very salient out of this is for every day, they don't want to engage with interactive AI for the purpose that really our industrial partner wanted it for. It's not useful. People don't want it. They have no interest in it. They have their heuristics. They're strong. They're in their head. No need at all. It's when it's unexpected situations outside of routine times, an unexpected situation happens. They need some decision of support. But it's actually this right side of the quadrant here, where you're in non-routine situations and you have these kind of anticipated need for new heuristics. Your routine changes unexpectedly, and all of that knowledge built on years and years of heuristics engaging with type 1 diabetes is lost. This is where technology plays a role. Or you end up in this unknown situation completely out of the blue. You need emergency decision support systems. So this is where the need is. So although we weren't able to solve the machine learning pipeline, we were, by doing these kind of co-design sessions and engaging with the future of machine learning for diabetes, we were able to get some design implications for industrial partner and other diabetes companies. With this said, so I do a lot of studying of forward now and backwards, but actually I'm quite slow in my research, and so is manufacturers, and these frustrations are universal. And in fact, it's causing DIY movements to happen. Hackers and motivated lay people are doing it themselves, doing it together for personal health. A very, very viral story was the We Are Not Waiting, which were a group which were releasing open source DIY diabetes hacks. And these weren't minor hack the Bluetooth things. They were also releasing open source artificial pancreas loops that worked pretty well, actually. But this isn't alone for diabetes. So prosthetic users and activists are 3D printing open source limbs. Hearing loss groups are forming around the design issues with hearing aids, and there are a lot of them. So user innovation has a lot of potential, but there's still quite a lot of issues, as you can imagine, with it, legal, safety, and whatnot. But it's also very exclusionary to people with the time and the money and the resource and the connections to do this. And that means that the user innovation is limited to that kind of what I call the 1% of hackers, where I think there's a lot of opportunity to kind of elevate the voices and scaffold in user innovation for underrepresented groups. So what I don't do, is quantify experience. So in all sorts of research, having objective kind of results are in some ways preferred, because it leads to quite easy suggestions for design features, but that is not me, and I don't think that is so useful for personal health because of its complexity. If you look at randomized controlled trials, those are the gold standards of medicine, but it's been shown that like apps prescribed to the NHS for CBT who have gone through randomized controlled trials, have used behavior change theory, have been looked at in the real world, how people are actually using it, and they've been shown to be harmful to mental health. This kind of quantified experience misaligns with technology development. You want to quantify the experience of an app? Well, by the time you run an RCT, the app has been updated twice. So what do you do then to stop innovation on technology? You can't treat it like it's a drug that goes through those steps in that way. Technology doesn't innovate the same way. It also misaligns with the complexity of the lived experience. You can't control multiple aspects of someone's life. It's not naturalistic, and it doesn't capture complexity. And my research has found that that absolutely influences how people use technology for their personal health, and therefore their personal health. And quantitative results from our cities don't capture the big picture. My favorite example is a collaborator of mine, Nikki Newhouse, working on, I think it was a smoking cessation website. And there was one outlier where a person visited the site, clicked on the homepage, so they had that quant data, and then they had quant data on if they had stopped smoking, which they did. And they didn't know the why. So they didn't use the website, but they stopped smoking. And when it was only after talking to that person, they're like, yeah, it took me going to the website to realize, yeah, I should probably stop smoking. So I stopped, didn't need the website, just change the behavior based on that. So people are weird, and it's very hard to quantify that. And lived experience should impact design. Emotion plays a role in decision making, including non-use and misuse. theories of psychology and behavioral science start to break down when you look at the complexity of everyday experience. These are centered around the individual and not the weird ecosystem, which is everyday life. And we know that social settings impact personal health significantly. You can't just look to the individuals. Individual differences are impactful and very powerful. And as silly as, well, they wear dresses and they don't have pockets, or they wear a bra so they can actually attach a device to it. So they're very personal and very individual. And so I think there should be a move towards bespoke technologies. I like to say that naturalistic studies are near impossible to capture. So the way that I go about it is taking a pragmatic approach to this kind of qualitative data to look at it. And I think you can look back to established technologies, now to current technologies, and even future to near future technologies to influence the design of these safety critical systems. So with that, I'd like you to thank my collaborators and funders who helped with this work, and in many cases led this work. And with that, I think I will say thank you, and I'll leave it over to questions, which I think are maybe in the Q&A. I'm not sure.
Thank you very much, Aisling, for that talk. It was really interesting and went into a lot of detail. We have got a couple of questions that have come through, and some of these areas you might have covered in the talk, but it's nice to kind of have a bit of a recap. You talked about the work that you've done, or the work that's been done with Samsung, Alexa, and Quinn technologies. Why is industry involvement in your research important?
Okay, so industry, or who are actually producing these things in any kind of way that would scale. So I do a lot of research on DIY, and they are open source and they have scaled, but it's not to the same extent. So they are the gatekeepers of much of this personal health technology, and many of those gatekeepers aren't trying to do personal health technology either. Samsung was doing the Gear Fit at the time, so like in some ways was looking at a wearable to quantify movement, really, in order to help people, but in this kind of sideways. So we'll quantify the movement, maybe they'll change their behavior to healthy thing. Alexa is not designed for health and care. People are just using it for health and care. So it's an interesting issue as well, because this type of research tends to focus on issues that emerge with technologies, and so that can be quite controversial working with a company. I think Quinn Technologies, who we did the machine learning for diabetes, benefited greatly from having an outsider group looking at their technology with people. So as part of the co-design, we're also looking at their current design. They were able to get objective insights into the design of their technology, which they have said they would have never got if they did it themselves. So people are very nice to the designers of technologies. Find that a lot when supervising master students and undergraduate students. You build something and to ask your friends how you did with it, they're going to be nice about it generally. So there's an objectiveness to engaging with the university and doing this kind of work in a systematic and kind of valid way that might be publishable amongst your peers. So I think there's definitely benefits from industry, and there's definitely benefits from the academic side as well, because again, they're the gatekeepers. We can do some design of health and care technologies to a certain extent, but it's always picked up by one of these gatekeepers at some point. So not being shy with them is probably a good way forward.
Brilliant, thank you. And within the presentation, you talked about the looking back, the current, and the looking forward. Where do you want to see your research in 5 years' time?
I'd like to focus on DIY. I really like what's so that the looking back, looking now, and looking forward. I've actually engaged with that kind of framework with DIY people, and engaged in what we call in human-computer interaction design fiction. So you you engage with near future things that might be possible, might never be possible, but people will have opinions on it, and you will provoke them into talking about things in interesting ways. And I've used that kind of framework of looking back onto old hacks, looking forward into what is possible, and then looking to the now, what people are actually engaging with DIY. That is a very interesting, understudied area, and has so much potential to make huge differences in the way people experience health and care technology, and therefore, I think, their quality of life.
Brilliant, thank you. A little bit more about the DIY movement, because it's not an area that I particularly know a lot about. Could you go into that in a little bit more detail? I appreciate it's open source in that area. Could you?
Yeah, it's a weird one for people to get a hold of, actually, because I remember giving these presentations before, and people are just gobsmacked that people have created their own artificial pancreas and have insulin, which is a great medication for diabetes, also a poison, set up to an autonomous system that is going into their body that didn't go through CE mark, that didn't go through the FDA. It's a challenging one to get your head around, but then you see what these people have been able to accomplish, and the innovation that they have been able to accomplish has been significant and has impacted manufacturers. For instance, in the DIY diabetes movement, the We Are Not Waiting, their first major success was something called Night Scout, which is essentially just hacking the Bluetooth of a continuous glucose monitor and putting it onto those results onto a watch or a mobile phone. That doesn't sound so interesting, but it's so significant to the quality of life of a parent who lives on the other side of a house to a child who has diabetes. And diabetes is a chronic condition that can be balanced, but has significant impact. There's a term called dead in the bed, people dying in the middle of the night from hypo incidence in diabetes. And so your child has diabetes, they're on the other side of the house, and access to where they are in their blood glucose levels sits with them on the other side of the house, because it's Bluetooth, and Bluetooth doesn't travel very far. So manufacturers hadn't created a solution for this, which was atrocious to people, to parents mostly, but most people thought this was atrocious. Why have we not taken that data, put it to the cloud, and put it on a parent's watch with an alarm system? And so they did it, because of course they did it, and they did it really quickly. They did it so quickly that they beat all the manufacturers who were looking into this, and in fact influenced the FDA to open up personal data and regulate it in a completely different way. And they influenced the FDA to fast track one of the manufacturers' versions of this so that there would be an FDA approved one. It's an incredibly interesting area for innovation, and you can imagine it's also very interesting with regards to legal issues. The fact that it's open source is in many cases linked to the idea that if it's an open source medical device, you won't get sued for it. You take it into your own hands if you download that code and you run it. But yeah, there's safety issues, there's ethical issues, there's access issues, because the vast majority of these people, or at least when I was engaging with it, are the people who have sold their startup, have diabetes, or their child has diabetes, is able to take time off of work and devote their time to that, and the skills to devote their time to that. So you can imagine there's not a lot of single mothers who are up there with kind of the role model hackers. It's a lot of tech bros out of San Francisco who are engaging with, and I don't want to disparage them because their impact has been massive, but they are the ones leading the innovation. They're making the design decisions for other people and sharing them, but they aren't from underrepresented communities in tech innovation. I think there's a lot to be said, a lot of opportunity to kind of influence things and get new ideas, because yeah, I think there's a lot of lip service paid to diversity, a lot of lip service paid to equality, but actually this is where really interesting innovations and new ideas come out of. So something like DIY and kind of scaffolding underrepresented groups, I think could be a great source of innovation there.
Brilliant. Thank you very, very much. This brings this session to a close. I'd like to thank you all for your questions and attending today, but I'd also like to thank our speaker, Dr. Aisling O'Kane. In the current climate, online is the only way we can really do these kinds of talks, and we really appreciate it's not as interactive as we'd like to do, to be able to have that chat over a cup of tea with a biscuit or a piece of fruit afterwards. If what you've heard today or throughout the week has captured your interest, please do get in touch with us. You've got Aisling's details there, and we'll follow up with a slide. Our industrial liaison office are here to connect you with our academics, our students, and any contact details will be sent after this. In light of that, again, I'd like to thank Dr. Aisling O'Kane for speaking with us and delivering a very thorough presentation. Thank you very much. And thank you all for attending.